Well, we've reached the bottom of the hour, and so I think I'm going to get started here this morning. I have the incredibly wonderful opportunity to deliver this stimulating and exciting lecture on hospice eligibility. And no matter how hard I try, it's really not all that easy to fill it with fun and amusing anecdotes. But it is something that y'all got to know. And so for the fellows, even if you're planning on doing mostly palliative as a career, you need to understand the ins and outs of hospice eligibility for the patients that you serve. And on the real pragmatic level, if this stuff's going to be on the board. So it's important to know that for those that are not directly involved in as a fellow. You all need to know this stuff too, and so sometimes a refresher is worthwhile. So let's bring the slides up, and are they
Yeah, we can see them.
perfect? All right, you can see them, and I can move them. So objectives are pretty straightforward. These are your objectives for this week and next. This is such a great topic that we can't cover it in 1 week, so we'll do it in two. But we're going to discuss the hospice benefit relative to the concept of eligibility, which is one of the more important aspects of this whole business. I have had the interesting hobby over the last 20 years or so of working with law firms who are trying to defend hospices, who have been accused of misdeeds by the government, sometimes of fraud and abuse. In one case, I actually did some work for for the Department of Justice, who was going after one of the so-called bad actors. I've decided that as hobbies go, I'd rather do golf. So I haven't done as much of that recently. But through the years, it's really been fascinating to me to see how the concept of eligibility has been interpreted by hospices. And there are a lot of very, very good, well-meaning, honest people who take in people that are eligible and just really document poorly. So part of what we're going to talk about is the importance of not only understanding eligibility, but making sure that the chart reflects that. And I'm not necessarily too worried about the people in this room on this call getting caught up in the trap of fraud and abuse as a practice, but it's important sometimes to understand how people skirt the rules and skirt the law so you can avoid doing that. So we're going to talk about eligibility. We're going to talk about the regulatory requirements, the conditions of participation, or the COPS. If you're not familiar with that term, COPS, you need to be, regarding initial certification, recertification, the role of prognostication, and we've had both one full lecture on that, and people in other lectures have touched upon that. So we're not going to spend a ton of time doing that, other than as it relates specifically to eligibility. We're talking about guidelines, eligibility, approach to determining eligibility, and educating on that stuff. So just a little bit of background. The Medicare hospice benefit was established in 1983. It actually was voted on and in a rare move of Congress, where the left and the right worked together and did something that was really, really good for the country. It really was kind of interesting to see that evolve. And they established a lot of the background, the bones of the hospice benefit as we know it today. Prior to that, there really was no funding mechanism for hospice services, and hospices in the United States were primarily volunteer organizations. Since that time, there have been a lot of modifications for example, in the initial iteration of this, the 6-month prognosis was pretty firm. And if your patients lived 181 days, you had people knocking at your door, figuring that you are committing fraud because the patients are still alive. They now have softened that so that you can have an unlimited number of 60-day periods after that. We're going to talk more about those, but that's just an example of how they have modified a little bit. They've also become a little bit more stringent over the years in terms of better defining, for example, what the GIP benefit really means and who qualifies for that. But one of the challenges with the benefit is it's 40 years old. And a lot of life has changed in 40 years. A lot of technology has changed in 40 years, and the benefit has not kept up with that. So there's some work to be done, but it is still our guidepost, and so it's important to understand that. Just as an aside, the one thing I want to comment is that as people, especially if you're interested in doing international work, as close as as north of the border in Canada, nobody else really has this in the world. They don't see the distinction between hospice and palliative care. They don't have the type of guideline for that. For example, in most of the industrialized nations, there's not this issue of are we going to cover hospice or not. It's just part of the normal government-sponsored healthcare program. It's not segmented out. It's not in some way distinguished itself from other aspects of healthcare relative to reimbursement. Within the country here also, what we have found that Medicaid and private insurance have pretty much followed suit with whatever Medicare has decided to do about the hospice benefit. And that's why if you have Aetna, Blue Cross Blue Shield, they will have similar eligibility criteria as the hospice Medicare benefit. So let's just talk just a little bit about the COPs, the COPs, the conditions of participation. And I just wanted to acknowledge up front Mike Raffleson, he's also program director down in Kalamazoo, and is essentially officially retired from most of his hospice work, used to give this lecture, did a fantastic job doing it. And so most of the slides are courtesy of him. So you notice on this binder here, the Hospice Care of Southwest Michigan, which doesn't even exist anymore by that name. But just wanted to acknowledge Mike for the work that he did in helping to put this presentation together a few years ago, because a lot of it is still valid. So the COPs govern the manner in which hospices provide care to the patients. And this is a quote from it. In regards to hospice admission and eligibility, the hospice medical director must understand the rules, regulations, and guidelines, and must keep abreast of key updates and changes. So the other thing to understand is that if you're not familiar with the MAC, which is the Medicare Administrative Contractor, that is the organization that the government contracts with to pay your Medicare bills. So whether you're a hospital system, an individual provider, or a hospice or home health agency or whatever, if you're going to bill Medicare, that payment, the evaluation of the claim and the payment always comes through a MAC. And you may not recognize that, but it does. And that becomes important because the MACs ultimately interpret what you are writing and what you're putting in the chart as whether that constitutes sufficient documentation for eligibility. Now, requirements for eligibility are pretty straightforward, and you'd think this would be fairly simple. The beneficiary must have Medicare Part A. The beneficiary must be certified by a hospice physician, and the attending physician, if any, as being terminally ill with a life expectancy of 6 months or less, and this is the important part, if the illness runs its normal course. We're not that great at prognostication, turns out. We can come pretty close at times. We've talked about the concept of days to weeks, weeks to months, months to years, but I've had people in hospice for 4 years with metastatic pancreatic cancer. It didn't run its normal course, and we had no reason to understand why it shouldn't, and that patient was eligible throughout the course of its hospice stay. And finally, the beneficiary must elect a palliative course of care. Now, again, just relative again to the Medicare issue, you as a hospice are entitled to take in patients who don't have Medicare, and they are not governed by Medicare rules. And so you must say, oh, then I can take anybody in. And the answer to that is sort of. The state of Michigan, who licenses your hospice, has a set of rules as to what constitutes eligibility, which pretty much map out the criteria. However, the state of Michigan, since they're not really paying the bills, if it's not a Medicaid patient, they really don't care. They're not going to be coming knocking on your door saying you're violating your license if you take in someone that lives 8 or 9 or 10 or a year. So just so you know that someone who is not Medicare does not necessarily have to abide by the Medicare rules and regulations. So the requirements, they must also sign a statement of choosing hospice care instead of other benefits Medicare covers to treat your terminal illness and related conditions. They essentially are saying they're going to forego other sorts of curative treatments, and if in fact they choose the hospice benefit. As you are probably aware, if a patient elects hospice benefit for that terminal diagnosis, at that point in time moving forward, the hospice is responsible for all of the expenses related to that terminal illness, which is why conventionally hospices will wait until someone has finished their chemotherapy or their radiation therapy before admitting, because once they choose to admit, they're now responsible for those costs. Coverage includes all items and services needed for pain relief and symptom management, medical, nursing, social services, drugs for pain symptom management, durable medical equipment for comfort, aid, homemaker services, spiritual and grief counseling for you and your family. So again, all of the supportive care relative to that is part of the benefit. Now, it gets us into this this little circle of, number one, providing that appropriate care. And we know that in most circumstances, we'd like to admit earlier if possible. That gives us the best outcomes, it gives us cost savings. You can do a lot more if you've got 2 months to help with that patient than if you have, 6 days. And you balance that with the being compliant to the regulatory guidelines. Because there is regulatory scrutiny that changes every year in terms of what the government's going to focus in on relative to their attempts to try to keep people in line. They try to uncover fraud. They sometimes engage law enforcement entities. So that balance is one of the things that we have to try to negotiate. This slide's a little old, but it still is relatively true. We have close to 2 million now Medicare beneficiaries that are receiving hospice care on an annual basis. And the hospice represents close to 40%, close to 50% of Medicare deaths. So those that have enrolled in hospice represent about 50% of all Medicare deaths. And you might say that's pretty good. We think that's pretty poor, that we know that probably 90% of those deaths were at some point in time in the trajectory of their disease eligible for hospice services. And so there's still a big gap there. In other words, there's still a lot of Medicare patients who could be served by hospice. Spending has also increased, as you would expect. It's really from a budget perspective, it's budget dust. We spend now about $1 trillion a year on health care through Medicare, and about 2.5% of that is spent on hospice services. And it's really unfortunate that in some corners, the legislators and sometimes the regulators see that now $25 billion as a potential target for recouping wasteful spending. That's not where most Medicare fraud is. There is some, and I'm going to talk about that later today or tomorrow or next week, about where the fraud is, how to identify it, and how you can be a part in helping to to prevent it. But we are inundated about every 3 months or so. There's a large expose or an article that comes out about hospices that are being attacked, and in some cases it's warranted because they've made some mistakes. But in other cases, and I mentioned there's 3 of them there: San Diego Hospice, the VNA Hospice, and Haven Hospice, are hospices which have been large, venerable, not-for-profit, outstanding organizations that got caught up in a web that, even if they did nothing wrong, it cost them millions of dollars to defend and try to unwind the issues. So how do you manage this tension between wanting to be compliant, but you want to take care of the patient as best as possible? The first is, and it's a simple one, it sounds pretty obvious, know the eligibility criteria. That's what we're going to spend the bulk of today talking about. Be thorough in your assessments and even more thorough in your documentation. Consistent documentation is important. I was reviewing some files last night, and I saw a certification of terminal illness, or what we refer to as the CTI, that said 91-year-old dementia getting worse. And I thought to myself, someone needs some education. That patient may very well be hospice eligible, but based on the physician's certification of terminal illness, which is one of the things that they look at, you'd have no idea. I had to go digging through the chart to find the nurse's notes and hospital records to try to affirm that hospice was rightly admitting that patient. That's not a hospice from anywhere around here, by the way, so you're all okay. So the consistent documentation is important. This is another thing that I've not seen in our neck of the woods, but it happens. Incentives, performance goals, conflicts with clinical decision-making that can influence a physician's decision-making capacity, in which the hospice incents the doctor for referrals. Where I've seen that most is where hospices have part-time medical directors, and perhaps they may serve as a hospitalist in a hospital as their full-time job, and they serve as a part-time hospice medical director as a side gig, and the hospice gives them a couple $100 every time they admit one of their patients from the hospital. You can't do that. That's illegal. Setting performance goals to say, well, if you meet a particular threshold, then you get a bonus. And then the other thing is where you have administrators trying to dictate to the physicians who they want you to admit and what they're going to pay for or not pay for. That becomes particularly problematic when you have, for example, someone who has a hematologic malignancy and has this chronic anemia. They feel better with their transfusion, and it gives them 2 or 3 weeks worth of symptomatic relief. And an administrator says, no, you can't do that. You have to discharge them because we're not going to pay for the transfusion. We're going to talk about those types of things again later on, but really that conflict can be very real when you as a physician have a great sense as to what needs to be done for the patient's benefit and what an administrator tells you you can and can't do. So we'll talk about managing that conflict as well. At the end of the day, you keep patient needs and welfare as the absolute priority. I should just mention, if along the way, I don't have my chat box open, so if someone has any particular questions, comments, or needs clarification, please just unmute and holler out. I'm going to talk about just one case. I was not directly involved in this. I was peripherally involved in this case, so I was well aware of it a few years ago, in which the United States came to a Seracare claiming fraud and abuse. It was a $202 million judgment for filing false Medicare claims for patients that the government claims were not terminally ill. And without getting to the nuts and bolts of the case itself, ultimately the ruling outlined the need for a separate, what they refer to as falsity, not just a difference in opinion. And this was a quote from the final judgment. The opinion of one medical expert against another cannot prove falsity without objective evidence of other falsehoods. In other words, if I as a physician say, I really felt this patient was terminally ill, and you, who did not see the patient, says, well, I don't think so, unless you can provide me evidence why that patient was not terminally ill with specific objective evidence, my opinion is valid. And this really kind of turned the MACs on their head in terms of how they were evaluating these. The court held that in order to show the required falsity under the False Claims Act, the government must show something more than mere difference of reasonable opinion. And the court also agreed with Sarah Care that the LCDs, which we'll talk about in detail, are not binding guidance. They're not binding checklists for eligibility, which a lot of the MACs had done for years. The court noted that nowhere in the statute did Congress require that a terminal prognosis be retroactively proven accurate, only that the physician's good faith best estimate be true at the time. So this was a really wonderful stake in the ground for hospices who validated that we as hospice medical directors can in good faith and with evidence that we have in front of us say that this patient is eligible, and you can have confidence that someone, in a dark corner whose name you don't know and face you will never recognize can say, no, it's not. No, he's not. So, and it's important precedent to combat the claim that a good faith medical opinion can be false for the purposes of False Claims Act liability, both in hospice and potentially beyond. But this is what really did. And so that has not stopped the MACs from launching investigations as to their questions about eligibility. It's just that it has not been prosecuted through the False Claims Act. So this lecture will be available on the YouTube site if you want to download it. This and click on this link. This is the law. It is the Hospice Benefit Policy Manual. It's available online as an internet-only manual. It's not light reading, but I find it curiously interesting. I don't reread it a lot, but I refer to it now and then, and it's interesting to see what it actually says versus what convention has sort of bled into our culture. Another great resource through NHPCO, and you can just get this from the website, which is now the Alliance. If you're not familiar, NHPCO merged with the National Hospice and Home Care Association, NOC, to form the Alliance, which has been a good rollout. They've done it very, very well. All these materials are still available, and you can still get there through NHPCO. But they've got some great resources at all. So let's talk about the benefit periods. Hospice care is organized into benefit periods, and it consists of 2 90-day periods and an unlimited number of 60-day periods. So that almost always is a question on the board. So it's not hard to remember. So you get 2 90-day periods, which constitutes up to your 6 months. And after that, then an unlimited number of 60-day periods. And they shortened it to 60 days because they really want the hospice team to verify that if someone is living beyond that 6-month period of time, that they truly have something that, if it ran its natural course, should or would result in death. And the eligibility must be established at the start of each new benefit period. You're familiar with the face-to-face evaluations. If not, you should be, because the regulations now require that once you get to that 3rd benefit period, again, we've completed 6 months of the admission. We're now into the 3rd benefit period. Before the start of the 3rd benefit period, there is a face-to-face evaluation as well as a written certification of terminal illness and eligibility. The face-to-face can be done by a nurse practitioner or a physician. And the certification of terminal illness and eligibility has to be written by and signed by the physician. So most hospices now are engaging nurse practitioners for doing the face-to-face, simply because it's an economic issue. Generally speaking, nurse practitioners are less expensive to hire than physicians, and there is no reimbursement for that particular visit. We'll talk more about the billing issue later, but basically hospice medical directors cannot charge and bill for patient visits that are administrative in nature only. And by definition, the face-to-face visit is an administrative visit. You are, in fact, allowed to have one visit to a patient count for both a symptom management visit and a face-to-face visit, and you can bill for that, but you need two pieces of documentation in the chart, one being that visit and what you were doing that made it a medically necessary visit, and then a separate one that constitutes the documentation for the face-to-face visit. You can do that and then bill for the medically necessary part of that. So that's one workaround, but in many circumstances, they have found that physicians went out to do a face-to-face and sort of manufactured another reason to be there. That really doesn't fly if that's sort of gaming the system. So if you're going out to see a patient and they're close to their face-to-face, the need for the face-to-face, you can do them both, but make sure it's documented why you're going out there for the medically necessary visit. This is a really complex graph, and if you're on your phone or a small iPad, you may not necessarily see it as well. But this is just basically the algorithm, and you can see that up here you get a referral of patients enrolled in Medicare Part A, so they would qualify potentially for the benefit. You do the assessment. That's what we do. And we'll go through those different pieces. I'm not going to talk about those in this slide. And as a result of that initial visit, which is done almost always by the nurse, there's a decision made in conversation with the physician. Is this prognosis greater than 6 months? If it is, you don't admit. If the physician's judgment that the prognosis is less than 6 months, then the patient is eligible, and you get the verbal or written order to admit from the hospice medical director or hospice physician and a non-hospice involved physician if one exists. Part of the deal is you need two physicians to validate that. Typically, if you're getting a referral in, there has been a physician involved in that somewhere along the line. Now, not always. There's circumstances in which a patient may self-refer into a hospice. A family member is recognizing the burden of taking care of someone who's very sick, calls the hospice asking for care, and that will prompt an assessment. And if you find that the patient appears to be eligible, then you need to track down another physician who can certify that patient. But in many cases, you get in and you find that it's just that the family needed help. It's really not a terminal illness, it's a chronic issue, and they're not eligible. But in the physician's judgment, if the prognosis is less than 6 months, you get the order to admit, and you do the certification narrative, you do the attestation, and you are good to go after the signature. Again, if there's not enough prognosis supporting information, get more information, especially if this referral comes from a hospital or from a physician or from a clinic somewhere. That means that there's a doc that's been involved. And I always respect that and would call the physician saying, hey, we've got your patient in here evaluated for hospice services, and I'm not seeing it. What are you seeing that suggests to you that this patient has a limited prognosis? And in many circumstances, they'll share with you the information in which you'd say, oh, that makes perfect sense. That's great, we'll admit. Other cases, it's an opportunity for educating the physician that I understand where you're coming from and how you could see that this patient is going to be terminally ill. Unfortunately, it doesn't meet the criteria that we set for eligibility. So we will follow along socially for a period of time, and if things change in the interim, let us know, but then you would not admit. So that's really the algorithm that we follow. Any questions about that at all? So I'm going to share just a little bit about some of the most common diagnoses and the information that we use in determining eligibility. And then we're going to talk medical guidelines for determining prognosis in certain non-cancer diagnoses, prognostication relative to eligibility, and some tips and some tricks and some traps that we might find ourselves into. Again, this goes back a few years, but it's still pretty close to accurate. When the hospice benefit was developed, it surrounded a cancer diagnosis. That is really what people were looking at, and the need for these significantly important and valued and necessary services for patients that are dying with cancer. So the prognostication issue never really was that much of an issue. In the 80s, of course, we didn't have the tools that we have now that extend prognosis on cancer patients. And everybody recognized that someone with a terminal cancer typically had a burden of symptoms that needed to be managed, and that's exactly what hospice was developed to do. Over the years, it is the non-cancer diagnoses which has sort of taken over, and there was nothing in the benefit that prevented that. It just became a little stickier when it comes to trying to predict prognosis in the non-cancer population. So as you can see, a few years ago, and again, these numbers are still pretty close, a quarter have some element of dementia, nervous system disorders. And in fact, it got so bad 20 years ago, there were so many hospices that 90% of their diagnoses were Alzheimer's, or at the time, they would just call it debility or failure to thrive. So we're really not sure what's going on. This patient looks like they're failing, and so we're going to bring them into hospice. And this debility and failure to thrive diagnoses became the bulk of hospice diagnoses. And they said, hey, wait a minute, this isn't kosher. Patients are living for 3 years without a specific terminal diagnosis. So they eliminated that from the primary diagnosis category. You can use Alzheimer's, you can't use just plain dementia. And you can't use debility, and you can't use failure to thrive. But still, 25% are in that category. 25% cancer, and about 20% in the circulatory area. If you throw heart failure in there, that's closer to 30%. So you got 80% just out of those categories. And then everything else falls off in terms of frequency. Again, if you look at length of stay, the length of stay for these neurologic or mostly dementia patients, or patients that are having some debility cloaked in some other diagnosis, those constitute most of the long length of stay patients. When I was reviewing files for these hospices under scrutiny, almost always the issue was a patient that had Alzheimer's disease, no comorbidities, and they're still in service 2.5 years later. So they are long length of stay patients. COPD, again, very unpredictable in terms of their prognosis. They look like they're going to die tomorrow, and they don't. The heart and circulatory also, and cancer, maybe a couple of months, and all others about a couple of months. So, information that we use in determining hospice eligibility. One, obviously, is the patient's current medical condition and likely terminal illness. Also, any comorbid conditions that contribute to poor prognosis. When we talk about the specific LCDs, and we'll get into that in more detail, because you can have someone that has advanced Alzheimer's, but they can live for years, and we're certainly aware, and we've seen that, in which they may live for 3 or 4 years, unless you have a comorbid condition that would suggest that they're going to die sooner. So if they have, for example, congestive heart failure on top of that, if they have a stage 4 pressure injury, if they have pyelonephritis, if they have aspiration pneumonia, if they've had a fracture, something that would say, now we've tipped the scales. And So having a comorbid condition with any diagnosis really helps. Their physical ability and functioning can be very useful in determining how well someone is going to do. A history of hospitalizations and complications also is quite relevant in terms of just helping to understand what does this patient really look like, and what is their likely prognosis on the basis of their constitutional issues. Specialist's opinion, that's very valuable to me when I have a neurologist or I have a cardiologist that says, given what I'm seeing, I don't expect this patient to live much longer. And then you can look at the trajectory, progression, decline, and also what are the goals of care, because that's relevant as well. By definition, patients who come into hospice have something we can't fix. And so I think that's important to keep in mind. However, many diseases now that are not fixable have disease-modifying therapies available that could extend prognosis, perhaps with some burden. You look at end-stage renal disease, for example. Someone has dialysis, which could keep them alive a lot longer. But they may say the burden of this is just something I can't bear anymore. So what are the goals of care? Because that's relevant as well. So, often it's a combination of factors, and you have to make sure that you, as the certifying physician, are able to knit those together. And all relevant diagnoses need to be documented. If you're going to say, for example, congestive heart failure is one of your criteria for helping you make that eligibility determination, you ought to have something in the chart that documents that, whether that be a demonstration of the New York Heart Association category, whether that be an echocardiogram that showed an ejection fraction of 25%. If you're going to use that as a comorbid condition, you can't just say recurrent UTIs, because I don't, as an evaluator, I can't tell you how that relates to prognosis. So make sure that they're relevant diagnoses. So the way that I sort of look at this, at the end of the day, when I'm evaluating someone for eligibility, I look at these three things. Number one, what's the patient's diagnosis or diagnoses? Because in many circumstances, the diagnosis itself can confer eligibility. In most circumstances, that is going to be a metastatic cancer, something of that nature, or if it is a cardiac disease or neurologic disease, it's because the current diagnosis in and of itself confers that. Someone who has had a severe cerebral infarction, for example, they've had a stroke, they're not receiving care to try to extend life, they're unresponsive, they're profoundly hemiplegic, they have dysphagia, feeding tube is not being put in. Their diagnosis in itself can confer eligibility. What is their current clinical status? We have all seen people who sometimes the diagnosis may not even be clear, but we can see that their clinical status is such that if they stay in this particular condition without interventions, that they're not going to survive. And this is a lot of our ICU patients who have come in with either traumatic or medical issues from which they cannot overcome. So what's their current clinical status? And then decline over time. Again, independent of what the diagnosis might be. If I'm looking at someone and we've seen progressive weight loss, debility, loss of function, increased dependence on others for ADLs, just this decline over a period of time, and let's say that's happened over a period of weeks. Again, this quite often I would see in the very elderly, the nonagenarians and the centenarians and your 90s and upper 90s, 100 and some year old patients who they're just failing. It's not that a particular disease has overtaken them, but we can see that over the last few weeks and months, their body is simply shutting down. So if those things are in place, then I consider them eligible. Now, in the case of the last one, I may have to start digging a little bit to try to find what's the actual diagnosis in someone who has the dwindles. someone who is just simply failing now, because I can't use failure to thrive, I can't use debility. I might be able to use a malnutrition diagnosis, dysphagia, something of that nature. But I always, if I look at someone and I'm absolutely certain in my heart of hearts, based on what I'm seeing, what I know, that they're not going to be here in a few weeks or a few months, I will bend over backwards to try to get them admitted into hospice. And I might have to try to really scrutinize their clinical situation and their chart to try to find out what is it that makes me think that. And that's really painting the picture. What is it that makes you think that this patient is in fact going to die within the next few months? Paint the picture so that anyone picking up that chart understands that. You have to keep in mind, and I never have constructed my medical care or my medical decisions based on regulatory scrutiny. However, your documentation, perhaps you ought to think about who may be reading this and making decisions relative to eligibility. So painting the picture, and a lot of the times the first line of screening is someone who is not a physician, may not have any particular medical background, but they are trained to look for specific keywords and key phrases in the documentation. And in fact, there's a great suggestion now that AI will in fact be one of the factors in making some of these preliminary determinations. So the LCDs, local coverage determinations, you need to know about these. The first edition came out, again, 30 years ago, and it was sort of by accident. There was a task force through the NHPCO, some physicians that were really helping to develop some specific, they wanted some specific criteria. What is it that we can look at that really helps our fellow medical director physicians in making prognostic determinations? And so they began doing this work with NHPCO, and the cat got out of the bag way too quickly, in which they said, oh, these are good, let's distribute them and see what people think. And within a relatively short period of time, it became gospel, which is unfortunate, because although these are widely used and disseminated, their practical use is limited by scientific evidence of their prognostic validity. None of them, and I emphasize that, none of the LCDs has scientific background of validity in terms of affirming hospice eligibility. So they are not considered to be criteria. They are guidelines, and you can use them. There are currently 13 disease states for which LCDs exist: heart, lung cancer, stroke, renal, liver, dementia, MS, ALS, HIV, AIDS, prostate cancer, breast cancer, lung cancer specifically. And so those exist. And if you look at them, and I'm not going to roll out too many of them, but for example, for cardiac disease, they recommend New York Heart Association 3 or 4. They're already on optimal diuretics and vasodilators. If they have an echo, an ejection fraction of less than 20%, the history of arrhythmias that are currently problematic, and this is not an AFib that was diagnosed 15 years ago and is currently under control. History of cardiac arrest, cardiac syncope, cardiogenic brain embolism, which is just a different way of noting, yep, they had a cardiogenic stroke, or concomitant HIV disease. As you can see, a lot of these were developed, even though the first one came out in the 90s, the mid-90s. HIV was still very prominent within our hospice environment. So those are the sorts of things that would show up on an LCD. Now, here's the deal. If your patient does not meet those criteria, it does not mean they don't qualify for hospice as a result of their cardiac disease. Important point. They can still qualify on the basis of their cardiac disease. But you're going to be painting the picture as to what it is you think about this patient's heart disease that makes them eligible, and that's what you're going to document. If they do not meet the LCDs, it's always prudent to have a sentence in there that you recognize that. Patient has ejection fraction of 35%. However, we have seen over the last 6 weeks that they have been hospitalized twice for decompensated heart failure. They remain edematous in spite of maximal medical therapy. They are now requiring oxygen and they're short of breath, and this represents a significant change that we're seeing week to week. Language like that is very, very effective at saying, okay, I may not know the ejection fraction, they may not be New York Heart Association 4 yet, however, that we've seen their decline over time, and their current status is such we don't think they're going to survive. The reason that's important to make a comment relative to the LCDs is that the regulators will use that, and they'll say, well, they didn't meet the LCDs. Well, they don't have to. But that's one of the pinch points that we have with how the MACs have interpreted these LCDs. They still believe that they are sacrosanct, and even though they're not, and even though the AseraCare case validated that they are guidelines and not criteria, a lot of the MACs still will rest on them. So it's important that you understand them, and basically, if you meet the LCDs, you're in good stead. A lot of times, the systems are set up to let that admission stand if they meet the LCDs. Again, lung disease, severe chronic lung disease, dyspnea at rest, poor response to bronchodilators, FEV1 less than 30%, progression as evidenced by increased ER visits, hospitalizations for infections, increased medical care needs and visits, and a decrease in FEV1 greater than 40 ml per year. Just as an aside, I know a lot of you know I was diagnosed with IPF. IPF a number of years ago, and it was really kind of stunning to me when I realized that I met hospice criteria because of the extent of my disease. But again, I had an opportunity for disease-modifying therapy that extended my life, so I was grateful for that. Renal disease, creatinine greater than 8, 6 if you're diabetic. And this is an interesting LCD because we see all the time patients that have creatinines of 3, 4, 5, for whom dialysis has been recommended but refused. They may very well be eligible for hospice services. Again, this bottom one here with a creatinine clearance of less than 10 or less than 15 if they have heart failure is criteria for that. Now, you don't have to have a creatinine of 8 to have a creatinine clearance of less than 15. But this not seeking dialysis or transplant is relevant because it really helps us in terms of just validating that they're not going to survive this. Liver disease, similar sorts of things. The albumin is always a nice guidepost for this. Poor coagulation status, intractable ascites, and encephalopathy episodes that we see a lot of those. So you can start to see these guidelines are set up to really identify the sickest of the sick. And again, as I mentioned, if criteria for LCD guidelines are present, generally the eligibility for hospice benefit is established. And generally documenting these guidelines is very effective in established eligibility. And especially, and this is a big one, especially the nursing and physician notes are consistent. I can't tell you how many charts I have looked at in which the physician does his attestation, nurse practitioner has done the face-to-face, and it's an Alzheimer's patient that is, according to the nurse practitioner, is a fast 7D. They are immobile, total care. They have a stage 4 wound on the coccyx, and are being treated with an antibiotic for an aspiration pneumonia. And the nurse says wound is healing. That may be true, but you still need to document its stage. And you have a chaplain that is commenting, we had a very nice conversation about end-of-life issues and his memories of his brother, and how they like to go fishing. And so the language that's being used in the chart and amongst disciplines has to be consistent, or it's really going to confuse people and you may get snagged in a net. LCDs do not predict prognosis. It's based on opinion and the synthesis of then available literature, again, 30 years ago literature. There are no quantitative studies on the hospice populations with a 6-month survival as an outcome measure. It's really hard to do controlled studies on an end-of-life population. And so we just don't have the science that can back those up. And it's really questionable then if any set of criteria applied to diverse clinical scenarios will ever be able to predict a 6-month mortality. Nevertheless, it's still part of our role to assess that and to comment on that, because we may not ever be able to prove it. We talked a little bit about trajectory. You're all familiar with these. I won't belabor this, but just the different trajectories of dying. People want this one. Less than 10% of the population do. Vast majority have something like this or something like this. Either the terminal illness or the organ failure, and then there's a few that have the frailty. So just that really helps you in the prognostication type. The data we use in prognostication: physical measurements, observation, disease progression, input from the attending provider, from the consultants. Again, in many circumstances, you are affirming the terminal diagnosis without ever having seen or know this patient. You're doing it on the basis of chart review, or in some cases, simply on what the admitting nurse is telling you over the phone. Symptom progression, lab study data, nutritional data. There are different scales and evaluation information that you can use. We'll talk a little bit about those. Functional decline evaluation tools, cognitive, those are the frailty indices. Cognitive decline. Again, it's always useful to talk with the patient and family. What were you doing 6 months ago, 3 months ago, 1 month ago that you can't do now? Behavioral, social changes. And then, of course, the surprise question. And the surprise question, would it surprise you if this patient were no longer living in a year? There's variations of that, 6 months. A lot of times a year seems to be a better milestone to ask an attending physician, would it surprise you if this patient were not here a year from now? Because a lot of times it'll be very, very accurate in terms of predicting that. The physical measurements, your weight, BMI, vital sign changes, arm circumference. Arm circumference is notoriously inconsistent. It's really, really important that the hospice that you work for has an identified and practiced standard for measuring mid-arm circumference. Some will do it as a thigh circumference. And also keep in mind, if you've got heart failure and edema that waxes and wanes, this may not be accurate. People that are having renal disease and fluid retaining, this may not be accurate. But to see fluctuations of centimeters at a time from week to week is not helpful. And a lot of times what we're seeing is different nurses do it differently. You can't have that. There's got to be consistency in how that's applied. Walking distance, especially if they have some element of pulmonary disease, recurrent fever. So those are the types of physical measurements. Lab studies, again, I mentioned albumin, renal function, things that are changing over time. Nutritional data, their weight, percent of meals eaten. That is, again, a bit flaky, but can be helpful. If someone was eating 75% of 3 meals and now they're eating 25% of 2 meals, that's meaningful. And that is helpful for understanding prognosis. So documenting that is helpful. I've always found, though, it's just a little flaky because percent of what? If you're putting 3 eggs, 3 slices of bacon, toast, cereal, and an omelet on someone's breakfast plate versus 1 unbuttered English muffin. What they've eaten to that percentage-wise may not be relevant. Sleep habits, somnolence, it's important. How many hours a day are they now sleeping? And use that as a range, and if that changes in time, that has prognostic value. I mentioned the value of secondary conditions, aspiration pneumonia, UTIs or other infections, falls, especially injurious falls, non-healing wounds or ulcers, bleeding episodes, syncope. These patients and sometimes families say, oh, he had another one of those episodes. What did that episode mean? Well, he just didn't seem like he was here. He was nonsensical. He wasn't talking for about 30 seconds. Document those. Those indicate that something is going on, and the frequency of those and the length of those, in quote, episodes can be meaningful. Other scales and evaluative tools, there's the ECOG, which is Eastern Cooperative Oncology Group. And you will see that oncologists use that as a again, benchmarking whether or not patients should receive chemo. If they are, 4 or 5, sometimes if they're 3, they may not be qualified for chemotherapy. It helps us to understand what their functional capacity is, whether they're 0, 1, 2, 3, 4, 5. So you'll see the ECOG, again, greater than 3 is suggestive that they may be eligible for hospice services based on their status. FAST scale, you're all familiar with functional assessment scale. And generally speaking, if you know this and you know this, if you don't, most of us hopefully are in the 1 category today. Depending upon how much sleep you got, you might be a 2. But anyway, for hospice eligibility, that we want that in the 7. And there is nothing in the regulations that suggests it has to be 7 anything. So 7A, if someone is 7A and with respect to their FAST, they may be eligible for hospice services. Again, if it's in the 6s, they may be, depending upon what the comorbid conditions are. Also, it's important to remember that this scale was validated for Alzheimer's disease, period. I've seen people apply it to people that have had strokes, that have had vascular dementia, that have had other neurologic diseases. From a prognostic standpoint, there's no validity in that. It is good for Alzheimer's only in terms of its validity. Now, that doesn't mean we can't use it or that it doesn't have some value. When I see a FAST scale, someone who's a FAST 7C with a Parkinson's diagnosis, for example, I know what the 7C means in terms of their functional capacity. And while it may not have prognostic value in and of itself, that speaks to me in terms of what that patient's functional capacity is. And if it changes over time in particular, that's meaningful to me. If they were a 6E and 3 months later they're a 7B, well, now they have, they have just kind of gone through this level of now not able to meaningfully communicate. Speech is quite limited. They're totally dependent on 6 out of 6 ADLs. That's information that's helpful for them. But just to understand that the functional assessment test, this scale, the FAST scale, was validated only for Alzheimer's disease. Palliative performance scale should be done on every patient. Again, I find inconsistencies in how hospice staff apply this. You start on the left and you move to the right. So if you are a PPS of 50%, which means ambulation is mainly sitting or lying, okay, then this patient will be a 50 or less. You can't move up as you go across. So maybe they can sit and lie, but the only occasional assistant is needed for self-care because they figured out how to do it in bed. No, it's not a 50 to 60, it's a 50. They mainly sit or lie. So as you move across, then you might find, oh, they mainly sit or lie, but they need almost all assistance, not total care. So, well, that makes them a 40, okay? intake is normally reduced, full or drowsy or confusion. So they are a 40 because this mainly assistance in the self-care pulled them down. You might find that they're mainly in bed, can't do any work, mainly assistance, but their oral intake is significantly reduced. They're a 30, okay? So that's how you use the FAST scale. Make sure your staff understands how to use the FAST scale. Because there's inconsistencies, and I will see that where, again, in a face-to-face, a nurse practitioner has noted the FAST 30, the nurse says it's a 50. So you just can't have that in a chart. It's confusing, and it's going to result in some element of challenge for you. Alzheimer's, notoriously difficult to predict prognosis, and it's often one of the longest length of stays on the hospice benefit. Often the target of audits. Documentation is the key. And if I could say one thing about Alzheimer's, about it, it's this second bullet. You must have a significant comorbidity. You can't just have a FAST 7C and say, therefore, they're eligible. If they don't have a comorbidity, and I'm reviewing that, I'm going to challenge you, what is the comorbidity? Because you have to have it there. Or a disease-related complication. Aspiration pneumonia, pyelonephritis, sepsis, febrile episode, eating difficulty. Any of these things are, decision not to get a feeding tube with poor nutritional status and weight loss. That's good, okay? Dysphagia, that's good. You can have those things. The level of dementia is relevant, but if you don't have something other than Alzheimer's that suggests to me why they're going to die, you're going to get in trouble with regulators almost all the time. So make sure that that's there. Again, other tools, the ADEPT is the Advanced Dementia Prognostic Tool. This is helpful, it's useful, but it's only valid for nursing home residents. And so just be aware of that. If you're you can't use that. It's not been validated for hospice eligibility, but again, as some tools, it can be useful. The surprise question, again, we alluded to that earlier. Would you be surprised if the patient died in the next 12 months? It really was no is more predictive than cancer, than the type of cancer or age. So in other words, you ask the doc, would it surprise you if they died? If they said no, then 40% of them were dead. And if they said, yes, it would surprise me if they died, only 3% actually died. And so it's a tool. Mike Raffleson uses these three things to be present before admission: terminal illness, we've talked about that, goals of care, hospice aligned, and that the hospice has the resources to provide the care the patient needs. Not all hospices have the capacity to take, for example, care of someone who's home on a Miller-own drip. And we just have to recognize the limitations that some hospices may have. Again, do they meet eligibility? Is there another treatment plan that would better serve the patient other than hospice? If so, your obligation is to allow them to, and to perhaps facilitate them receiving that particular type of treatment. And if not, do try to qualify them. Finally, I'm going to probably end with this. Part of the role of the hospice provider is to educate about the hospice benefit. Again, as I've alluded to, documentation needs to be coordinated between yourself and the rest of the team. Part of your role as a hospice medical director is to educate the team, not only about the primarily about the hospice benefit, but how they can best document what they're seeing and how that helps you, who will be completing the certification terminal illness. There's a great misunderstanding of the benefits versus harms the patients might receive within hospice, and so our ability to educate is helpful. Healthcare providers are often the major source of misinformation about the hospice benefit, yet they are the most trusted source of information for patients and families. So again, I always insist that that hospice medical directors have a role and educating their referral sources, the community docs, and the folks at the hospital about what truly is hospice eligibility. When you're a community provider and you're talking to another doc, it's okay to provide the guidelines, but explain they are just guidelines. They're not etched in stone. Offer hospice informational visits. Offer phone and face-to-face evaluations by hospice provider to assess eligibility. When you're talking to a doc, says, I'm not sure, says, well, let's send somebody out and see what they do. You ask the surprise question. Offer medical director oversight of the hospice plan of care. I know for a lot of hospices, they prefer to have their medical director involved, or reassure that they can remain involved in their patient's care. Docs don't like being disassociated with their patients, and so affirming that they can be involved and that you will work with them and make sure the patient gets what they need is very, very reassuring. Okay, that's it. And, you know, I've got something blue on my screen. I don't know. Anyway, we're a little over time, but any questions, comments about any of that? We will have the opportunity to take that up again next week and continue this wonderful journey.